Yeah, thank you. Thank you very much. So the topic which has been given to me by Dr. Ganguly and team is apheresis, a new tool to treat many diseases. As Dr. Prashun Bhattacharya has also discussed, the range of the various diseases which can be managed by apheresis, either it may be an acute disease or a chronic disease. Next slide. Okay. So let us start with the history of apheresis. Apheresis technology is not a very old technology as per the world is concerned. And this technology was developed around 50 years back in 1970s. And there was one gentleman named Alan Latham. He was from Haemonautics Corporation of India in USA, who actually developed the concept of apheresis, right? And the recent concept of apheresis was introduced in 25 years ago just. Uh, 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 Today we are speaking of therapeutic plasma exchange, therapeutic red cell exchange, or therapeutic platelet reduction. And this whole concept into the treatment of patients by apheresis technology, it came around say 25 to 30 years ago. And apheresis license in the US was done in 1990 by the US FDA. এটা চেঞ্জ হচ্ছে না গো না okay. So to start the introduction, actually apheresis, this is a Greek term, okay, and the term apher, that means to take, right? So since if you take a platelet, then we call it as a platelet pheresis. If you take plasma, it is the procedure is called plasma pheresis, and if you take red cell, it is erythrocytopheresis, and so long and so forth. So apheresis is the Greek word that means to separate or to remove, right? And the main mechanism of this technology is that you draw whole blood from a donor or a patient, whoever may be, to the machine. And after the addition of anticoagulants, the whole blood is processed inside the machine, and then the machine separates the desired component. So you can separate any component of blood by means of apheresis. Maybe it is a platelet or plasma or leukocytes or red cell whatsoever, right? And the remaining constituents, right, are returned to the individuals. So we actually collect the desired component, and the other parts of the blood are returned to the individual. So here you can see, this is the principle of apheresis, just a schematic diagram. So if you see the right side, right, so you can see whole blood, and in the left side also you see whole blood. So from the vein, from the patient or the donor vein, anticoagulant is added, and then you separate the desired component. And after your desired component is separated in a special bag in the kit, then the remaining blood components combined with plasma is again enters into the donor or the patient vein, right? So you take whole blood, you give whole blood, just in the middle, you separate the component, you program, right? So it is just a computerized machine. So when you switch on the machine, you will see a lot of messages coming, whether you will be separating platelet or plasma or stem cell or granulocytes. So depending upon your necessity, you just click on what is the component to be separated, and then the machine undergoes the booting and preparation for the function, and then you start the apheresis, and the machine will collect the desired component. So this slide shows some historical machines from 1970 to 1990. You can see here B50 Haemonautics, CS3000 from Baxter, then Spectra Gamro BCT. So these are some historical machines, and I will not say that these are fully automated machines. A few components of these machines were semi-automated or actually maintained or run by manual methods also. But today, if you see the apheresis machine, which are available commercially in the market or in the hospital, right? These are all automated machines. So things are very easy nowadays compared to previous historical machines. These are the recent apheresis machines. You can see Optia, Teramobicity. This is a very, very new machine. Just came to India around 7 to 8 years back. Then the right side, this is the Amicus Phenuel from the company Fresenius, right? This is the left side small machine. It is from Hemonitis Corporation. And this is MCH, that is a mobile collecting system. You can carry this machine from one bedside to another bedside and anywhere in the hospital. And again, in the right side, the yellow color one, you can see it is a Comtech from Fresenius. So these are 4 recent apheresis machines which are available globally, right? And the hospitals and the transfusion service, they use one or the other machines, but the function of all the machines are same. Their looks are different, their colors are different, but the functions are same. Now, when you talk about apheresis technology, we should understand there are 2 parts of it. One part is that you collect a blood component from a prospective donor. That means you collect a normal blood component and you transfuse that component to a patient. So that is one part of apheresis. Another part of apheresis is that you remove the pathological substance from the patient by means of this technology. So now in the left side, I have shown you that there are specific blood components or cell are collected for transfusion or transplantation. So here the commonest, as you all know, component collected is the single donor platelet. So in our day-to-day practice, we use single donor platelet in the hemato-oncology or in the ICU or even in dengue epidemic. A lot of single donor platelet or platelet product are used, right? So in day-to-day language, we call it as single donor platelet, or in good language or in medical terminology, we call it as a platelet pheresis. Again, another important component which today we collect is the stem cell for the bone marrow transplantation or the stem cell transplantation in the hemato-oncological patient, or granulocyte collection. Sometimes patients suffering with neutropenia, right? Febrile neutropenia, the WBC count is 100, 50, 200. Then these patients require granulocyte. So we collect granulocyte from a normal donor and we collect it and we transfuse it to the patient who requires it. So this is the collection part by apheresis technology. And in the right-hand side, you can see it is a therapeutic application of apheresis technology, where the apheresis technology is used for the patients, right? So in most of the cases, why this technology is used? Just to remove the antibodies, or it may be lipids, it may be toxins, it may be endotoxins, it may be bilirubin, it may be bile acids, and a lot more, right? Any pathological substances can be removed by means of apheresis technology, depending upon the indication. Now, as I was talking about a single donor platelet, I think most of our students have seen this product in their day-to-day clinical work or in their blood banks or in their hospital. But just this is a pictorial diagram of a single donor platelet, right? So here you can see it is around 200 and 250 ml platelets collected by apheresis machine with the proper labelings as per the drug and cosmetic tag, right? And actually, when you talk about a single donor platelet, it is said to be 1 full dose of platelet. That means a patient who will be suffering from dengue or having a low platelet count, who requires a platelet, right? That if you give a single donor platelet, that means 1 full dose, that is 1 full bag will be 1 full dose that will contain platelet in the tune of 3 into 10 to the power 11. So in transfusion medicine practice, when your SDP, single donor platelet, contains 3 into 10 to the power 11 platelets, then only we consider it as a full dose of platelet, full hemostatic dose of platelet, which is said to be equivalent to around 6 units of random donor platelet. Random donor platelet, almost all the blood banks, all the medical colleges or institutes, they have this facility of random donor platelets, right? Collecting platelet from the whole blood. Okay, so it is said that 1 SDP is equal to or even more than 6 units of RDP, right? But what happens in RDP, we don't know the dose, because a donor comes, donates the whole blood, we collect the RDP, we store it. So we don't know the actual dose of that RDP, we don't know the quality of the RDP. But SDP, single donor platelet, by means of its collection procedure or the donor screening, we know from whom you are collecting the SDP, what is his or her platelet count, what is his quality, then only we collect that product. That product also, we know the quality of the product, how much platelet is there, how much leukocytes are there, Is there any red cell contamination? So you know the full quality of a single donor platelet. But for RDP, since there are 100 donors, whole blood donations, they are collecting 100 RDPs or processing RDPs, then it is not possible for us to know each and every RDP's quality or dose, right? So when you are collecting a platelet, always you know the dose and you know the quality of that particular product. Now, this slide shows the advantages of a single donor platelet. I think this slide is very important for our students also in their exam also. You can see higher quality of product already have discussed. Obviously, an SDP's quality is higher, much more higher than a random donor platelet. Multiple donor exposure is reduced. Of course, one SDP is equal to 6 RDP, and 6 RDP has been collected from 6 whole blood, and 6 whole blood has been collected from 6 donors. And obviously, there are multiple donor exposures in random donor platelet, but in SDP, you collect it from one single donor. So it is reduced, right? So when the multiple donor exposure is reduced, so obviously there is a reduced risk of antibody formation, alloimmunization to HLA or other antigens. Okay. And since the donor exposure is less, so there is a decreased chance of transfusion reactions or transfusion transmitted diseases like HIV, hepatitis B, C, syphilis, malaria, other things, right? And another important thing is that by the technology itself, inside the apheresis machine itself, the SDP or the platelet you collect, it is leukoreduced. Leukoreduced in the sense that 99.99% of the leukocytes have been depleted from that product. So whenever you use a single donor platelet, SDP, it is assured that there is no leukocyte in that bag. Why? What is the advantage of leukocyte not having leukocyte? Because leukocytes are the culprit for fever, chill, rigor, which are very common with blood transfusion. Even more common are with your platelets, right? Then you can give a HLA matched single donor platelet and fewer donor reactions, right? Another, but it is not that you are having money today, you have developed a blood bank, you have started the SDP procedure or apheresis procedure. All blood banks should have a valid license. All apheresis collection procedure should have a valid license from the DCGI, Government of India, right? And this apheresis program are actually run by a qualified licensed physician responsible for the apheresis program. And the equipment should be good, reliable, and in a proper working condition. But today we have 4 to 5 machines which are available throughout the world, and I believe that all the equipments are same. All the equipments are very, very good, reliable, and all are working nicely. But we should have well-trained, motivated staff to run a apheresis program. An operator must know its operation and troubleshooting. It is not that you switch on the machine and it started collecting the platelet, right? But in the middle, there can be some troubleshooting, and you should be well versed with managing this troubleshooting also. And there should be manual book, there should be SOP, which should be available for the operator, as well as the nursing staff, who are available during the procedures. And every procedure, right from donor screening, patient screening, details of apheresis procedure, what you have collected, what is the QC, everything should be documented. Because if you have not documented the thing, you have not done the thing, right? So these are the general requirements for single donor platelet or apheresis, right? So when you talk about SDP, single donor platelet, there are some selecting guidelines also that is available on the website, right? And but just to gist here, you should counsel the donor, explain the procedure, because many donors are there who have donated 50 times, but they have donated whole blood in the camps or in the blood banks. Never they have donated platelet. So they are not aware what is a platelet apheresis program and what is a single donor platelet, right? So you should counsel the donor that it is not like whole blood, which takes only 10 to 15 minutes. It is a long procedure because the screening of the donor takes around 1 to 1.5 hours. The collection of the product takes around 1 to 1.5 hours. So it is a 3 to 4 hours actually job, right, in the blood bank. So you should counsel the donor properly, explain the procedure, and this age and weight and everything, they are as per the guideline, right? But always remember that remember that the donor should not take any medicine that may affect the platelet quality. For example, antibiotics, aspirin, and other platelet aggregating drugs, right? And always there should be written consent of the donor because that is required by the by law. Okay. Now, another important thing is that selecting veins for apheresis, because apheresis is a lengthy program, right? I told you that one procedure takes around 1 to 1.5 hours. So your needle will be in the vein for this duration. So your vein should be very good. It should not be thin, or there should not be any hematoma or vein injury or chance of, say, other neurological complications of apheresis, right? So you should have a good venous access, which is very important, because your veins play a very important role for the procedure and as well as the quality of the product. Okay. Then after considering everything, we take a sample from the donor, we do the CBC, we do the TTI testing, that is the transfusion and the infection testing. And as you all know that there are 5 mandatory tests: HIV, hepatitis B, C, malaria, and syphilis, and this should come non-reactive. And obviously your hemoglobin should be more than 12.5, and your platelet count should be more than 1.5 lakhs per macroliter. So these are the criteria which are followed globally. Now, once these are fine, you consider for platelet pheresis. So the interval between 2 platelet pheresis procedure, it may be 48 hours to 72 hours, but as a safety in our hospital, our SOP, we actually consider 2 procedures in 7 days apart. Suppose the donor has donated today, Sunday, so next procedure will be around, say, next week, Friday or Saturday. Okay. And the maximum number of SDP donation per year can be 24 times. As you all know that whole blood, it can be donated every 3 to 4 months, right? So in a year, a donor can donate 4 times whole blood, right? But in case of apheresis, a single donor platelet, he can donate 24 times a year, because here you are collecting just 200 ml of platelets and you are actually returning everything to the donors, right? And this platelet you have taken 200 ml, it actually generates within 48 to 72 hours. So again, the donor is fit after 3 days, he or she is fit to donate the platelet. But always remember that the procedure number should not increase 24 times a year. Now, platelet pheresis procedures, the duration of the procedure is 60 to 120 minutes, as I have already told you. And our target yield is 10 to 10 to the power 11. 10 to 10 to the power 11 platelet per bag is considered as a hemostatic dose, as I have already told you. And when you switch on the machine will ask you how much platelet what is your target yield. Then you have to enter, it is 10 to 10 to the power 11. And by default, since it is a hemostatic dose, by default, the machine will show that whether you are willing to collect 10 to 10 to the power 11, you should say yes. Then it goes to the programming of 10 to 10 to the power 11. And time mostly depends on the vein, platelet count, and the machine. If your vein is very thin and the vein is not actually supporting you, then the donation may be cancelled. Again, the donation may take a lot of time also. Suppose your platelet count is 1.5 lakh and mine is 2.5 lakhs. Obviously, that the time taken to collect platelet from my vein, from my body, will be lesser than yours, because yours is 1.5 and mine is 2.5. But our target is same, 10 to 10 to the power 11, right? And it also depends on the troubleshooting. If you have been troubleshooting, then it may take a bit of time. Okay. And always remember that these are the adverse events of the donor. It can be with the patient also, it can be in the donor also, because whenever you do a single donor platelet or a therapeutic procedure, whatever apheresis procedure, what happens? You actually add anticoagulant when the blood is drawn from the body, so that the blood does not clot in the machine, right? So, so what happens? There is a chance of citrate toxicity, because this anticoagulant acid citrate dextrose, it causes calcium chelation, and it may cause citrate toxicity, particularly when your ACD, that is anticoagulant usage, is more. So what we do nowadays in the transfusion practice, before starting a single donor platelet, always we give some prophylactic calcium, say Shelcol 500 tablet di dilam, right? And in case of a therapeutic procedure in the patient bedside, what we do during the procedure, we actually start a IV calcium infusion, and it goes on throughout the procedure. And this is basically to avoid the citrate toxicity, right? And there may be some vasovagal reaction, which is very common with not only single donor platelet, it is very common with whole blood donation also. You have seen that. sometimes there is a hematoma, particularly when your phlebotomy is not good, your vein is not supporting, hematoma, vein injury, and these things may happen, but these are very less. Suppose if you are an expert in apheresis and you have done say 100 of procedures, maybe in one or two procedure you may actually encounter this type of adverse donor reaction. So you can see stem cell collection. So by this time, all our PG students, they all know that what is the conditions which are associated with stem cell collection and stem cell transplantation, right? So this is a long list of leukemia, Hodgkin's, MDS, thalassemia, multiple myeloma, autoimmune disease, neuroblastoma. So there are a long list of diseases where stem cell transplantation is done. And this is a picture where we are doing a stem cell collection from a patient of multiple myeloma, right? Now, in the last 5 or 6 slides, we have discussed collecting as a platelet from a normal donor so that our students know who can be a donor for single donor platelet and what are the side effects, what may be the side effects of a platelet collection, everything, because in their day-to-day practice, they will be encountering more single donor platelet and platelet apheresis than the other therapeutic part, right? So now, in the subsequent slide, we are coming to the therapeutic apheresis, right? Now, when we talk about therapeutic apheresis, what is it actually? Procedure for the clinical treatment of disease and blood disorders, right? So this is the definition, and it removes selected abnormal components or cells from the circulation while returning all the other components to the patient. So at the end of the procedure, we have removed the toxins and the unwanted pathological substance. So this is the simplest definition of a therapeutic apheresis. Now, these are the types of therapeutic apheresis. Key procedure number 1, very common, plasma apheresis, the therapeutic plasma exchange, right? So exchanging the plasma to treat the patient, right, in some clinical condition. And when you talk about right one, leukapheresis, that is the removal of white cells. So there are some conditions, there are some diseases where you have to remove the white cells then and then from the patient, right? Again, there is another therapeutic apheresis, thrombocytopheresis, that means removal of platelets, particularly in thrombocytosis, essential thrombocythemia, right? And another procedure is erythrocytopheresis, that is removal of red blood cells, particularly in some infections or sometimes in sickle cell crisis. So there are basically 4 types of therapeutic apheresis, one related to plasma, one related to removal of leukocytes, one related to removal of platelets, another removal of red cells, right? Now, platelet, when you talk about platelet reduction, that is let me see, this is the removal of platelet, which we call it as a thrombocytopheresis, right? So when you talk about platelet reduction of thrombocytopheresis, there are 2 main indications of platelet reduction. One is the primary thrombocytosis, that we call it as essential thrombocythemia. Onek patient dekha jay where the platelet count increases and increases, and one day it actually it exceeded more than 10 lakhs, right? Then comes the role of transfusion service to reduce this platelet. Another one is the secondary thrombocytosis, which we sometimes see after post-surgery. After there is a splenectomy, dekha gelo after splenectomy, there is an increase in the platelet count, and one day it rose to such a level, then you have to actually do the therapeutic intervention by apheresis, right? So there are 2 main indications of platelet reduction in the clinical practice. One is the primary thrombocytosis, another is the secondary thrombocytosis. Now, another reduction is the red cell reduction or erythrocytopheresis. And these are mostly done in polycythemia, where your hematocrit is very, very high. Just to adjust the hematocrit and to reduce the red cells, we do apheresis known as erythrocytopheresis. Sickle cell anemia, particularly in sickle cell crisis, right? This technology plays a very important role, where we can reduce the sickle cell and we can give the patient normal cell, so within 2 to 3 hours, right? It saves the life of the patient. Then malignant malaria, onek shomoy dekha jay in case of malignant malaria, your red cells are loaded with Plasmodium falciparum or your Vivax or whatever, and the load is so high that the patient is in ventilation or in the ICU, right? So you can reduce this infected red cell, and you can pump during the procedure normal red cells into the patient, which may save the life of the patient. Then WBC reduction or leukapheresis, mostly done in hyperleukocytosis, primary hyperleukocytosis or secondary hyperleukocytosis. Particularly, I know the students have seen that during leukemia, in many patients of leukemia, your leukocytes counts are increasing and increasing and increasing. So one day it is so much increased that you have to do a leukapheresis, right, to reduce the WBC then and then. So these are some indications of platelet reduction, red cell reduction, and WBC reduction. And another most important is the therapeutic plasma exchange. And I am sure that in most of the hospital who actually practice apheresis, the majority of the procedures they do is the therapeutic plasma exchange, right? And why we exchange the plasma? The goal is to remove a pathogenic molecule, protein, or a high molecular weight complex from the plasma. Either it may be a toxin, it may be a bile acid, or it may be any pathological substances, or it may be an antibody, right? In many neurological conditions, we try to actually remove the antibodies by doing plasma exchange. And may be used to provide a deficient substance such as an enzyme or coagulation factors, which is available in normal human plasma. What happens sometimes you see around 3 weeks back, we have done a plasma exchange to reduce the triglyceride of a patient, right? So triglyceride was more than 5,000 TG level. So we have to do a therapeutic plasma exchange to reduce the triglyceride, right? So therapeutic plasma exchange has played a very important role in removing these abnormal substances. Now, when we talk about TP, we should know what are the diseases which are indicated for therapeutic plasma exchange. It is not that all the diseases, any disease, any patient, you actually feed the apheresis machine and do the plasma exchange, right? So there are many case reports of successful treatment of disease by therapeutic plasma exchange. And if you go through the PubMed search, you will see that there are very high quality clinical trials which have been done relating to therapeutic plasma exchange. And as per the ASPA guidelines, ASPA is the American Society for Apheresis, whose guidelines we actually follow, right? Has published clinical guidelines categorizing the indications for apheresis. And today we have 78 diseases where therapeutic plasma exchange has been found to play a very important role, right? So, and they have actually separated or divided these clinical diseases in category 1, category 2, category 3, and category 4. Obviously, when you talk about category 1, apheresis is accepted as a first-line therapy, or either as a primary standalone or maybe with other treatments. When you talk about category 2, it is accepted as a second-line therapy. And when you talk about category 3, that means the role of apheresis is not established and decision has to be taken individually, because there are some reports where the actual result is very good. Again, there are some reports where the results are not so actually acceptable, right? So it should be the physician's choice wherever they want to do the apheresis therapy or not. And category 4, there are evidence that suggests apheresis is ineffective or harmful, but the institutional review board approval is needed, because most of the studies are ineffective or harmful, but there are 1 or 2 studies who have found that this can be done. So in that case, the ASFA has guided us that in category 4, institutional review board approval is needed, but category 1, category 2, category 3, we can proceed, right? Now, এখন যদি বলি category 1, the main diseases of category 1 are the Guillain-Barré syndrome. Of course, this is a practice since a long time, right? Then CIPD, AIPD, then myasthenia gravis, Eaton-Lambert syndrome, Good-Pasture syndrome, that is the disease of the glomerular basement membrane, Rapson's disease, hyperviscosity syndrome, TTP, thrombotic thrombocytopenic purpura, then hemolytic uremic syndrome, as Dr. Proshun has already told you, HUS. So this comes into the category 1. Again, there are other additions into category 1 like ANCA-associated RPGN, cryoglobulinemia, focal segmental glomerulosclerosis. Then after a liver transplant, when there is a ABO incompatibility, so to reduce the antibody level, we have to do a therapeutic plasma exchange. So there is a long list, right? Sydenham's chorea, kidney transplant, ABO incompatible, or acute liver failure, particularly when it is due to Wilson's disease, the category is 1. Again, these are some category 2 as neuromyelitis optica Davies disease, acute disseminated encephalomyelitis, right? Then cold agglutinin syndrome. There are some overdosing, like overdosing of drugs, right? Mushroom poisoning. Sometimes it is also done in some snake poisoning, right? Familial hypercholesterolemia or acute multiple sclerosis, severe SLE. So these are some category 2. Category 3 তে আছে acute liver failure, right? Severe warm AIHA, then Henoch-Scalon purpura, pemphigus vulgaris, heparin-induced thrombocytopenia, sepsis, hypertriglyceridemia, pancreatitis. So these are some of the category 3. And in the last line, if you see, there are some category 4 indications like amyotrophic lateral sclerosis, dermatomyositis, refractory immune thrombocytopenia, POEMS, schizophrenia. But most of the results are not convincing. But some authors have found them to be found to have some positive effect with therapeutic plasma exchange. So, but category 1, category 2, category 3, I think you can practice clinically. Now, when we plan for a therapeutic plasma exchange in a patient, right? Now, always remember that it is not a single donor platelet. যেখানে একজন donor আসলো 2 ঘন্টা শুলো, then we collect the SDP and we tell the donor, yeah, you can go home now. It is not a single procedure, right? When you consider for a therapeutic plasma exchange, the procedure number may be 3, 4, 5, 6, 7, 8, 9, 10, anywhere, right? So usually it is more than 3, and the maximum it may be 11, 12, even 15 also. So it is not possible by a peripheral vein, right? So you need a vascular access for that in the form of indwelling catheter, large bore, double lumen. Either it may be a femoral line, subclavian line, or jugular vein, which can be maintained at least for 1 week. So this is the aim actually. So vascular access should be very, very good. And the volume exchange, কতটুকু plasma exchange করবো? Now it is, as per the ASFA guidelines, it is 1 to 1.5 plasma volume or 40 to 60 ml plasma per kg, right? So that means we should know how much plasma the patient is having. So how you can calculate that? So first you actually determine the whole blood volume. So roughly, suppose I am 60 kg, and now my whole blood volume will be roughly 70 ml whole blood per kg. That's 42, 4200. Now my hemoglobin or hematocrit is 30%, and the non-hematocrit part is 70%. That is the plasma part. That means out of 4200, my 70% is plasma. Or that means it is around say 2500 to 2800. That means that I am having a plasma volume of 2800. That means if I exchange 2800, পুরোটাই যদি exchange করি, that is 1 plasma volume. যদি আমি একটু বেশি মানে দেড় গুণ করি, মানে 1.5 times, then it is 1.5 times plasma volume. But if it is a pediatric, sometimes 1 to 1.5 volume is not working. So sometimes we have to take 40 to 60 ml plasma per kg, right? So this is the pediatric calculation. But in general, always remember that we can exchange the volume to 1 to 1.5. But we have seen in European countries or in USA, they even go for 2 to 2.5 plasma volume also. But that is a very aggressive type of plasma exchange, but we don't practice that in India. In India, we follow 1 to 1.5. Okay. Now, what component you are actually removing, whether you are dealing with an antibody IgM type or IgG type. IgM, we are very happy because IgM is a large molecule. 75% of these IgM fractions are intravascular. Synthesis is very slow. So whenever we deal with an IgM type of component, the apheresis result is very, very good, right? But when we talk about IgG, these are very notorious actually, because 50% are in the intravascular space, other 55% outside. So removal is not very effective. Synthesis is very rapid. As you know, the IgG synthesis is very rapid. Rebound IgG or rebound synthesis is very, very high. Okay. So if you do a procedure today, 2 দিন বাদে কি হবে, 40 to 40, after 48 hours, you will see that the level has come to 60% level again, yeah, within 2 days. So it is very difficult to counter a IgG fraction of antibodies. And if it is an IgM type, then yeah, the result is very, very good, and you can maintain a significant interval between procedures, right? Now, always remember that when you do a plasma exchange, it is not that some normal components are not losing. There are loss of normal components, but this are not very significant, right? Sometimes there is a loss of fibrinogen with the plasma, So you have to see that we are not taking out the normal fibrinogen and leading to hypofibrinogenemia. And sometimes some immune complexes and complements are also reduced with the plasma exchange. But these are seen mostly in high volume exchange, maybe 2 to 2.5 times, right? Or 1 point, even more than 1.5 times. But in day-to-day plasma apheresis or therapeutic plasma exchange, these laws are not very significant. Now, replacement fluid. You are removing the pathological plasma from the patient, but you have to replace this plasma, right, by something. So the most important component is the plasma, again, fresh frozen plasma, which are available in the blood bank, right? And there it can be 5% albumin, it can be cryopoor plasma or crystalline. But it depends upon institution to institution, it depends upon the institution SOP. For example, in Apollo, what I do, I mix albumin with fresh frozen plasma during therapeutic plasma exchange, right? And if the patient is having say coagulopathy, INR beshi hoye ache, then I insist on more plasma and reduce the albumin content. But in case of other like a Guillain-Barré syndrome kochi ba myasthenia gravis kochi, jekhane almost the patient is stable otherwise, so we do 50% albumin ba 50% fresh frozen plasma. Suppose today we are replacing 2500 ml of plasma from a patient. That means 1250 ml plasma devo, 1250 ml albumin devo. So this depends on you actually. You can use 100% plasma, you can use 50-50, or in some institute they don't use plasma because it has some side effects, like always a blood transfusion is always having a side effect, and sometimes in giving more plasma it leads to some allergic reactions, urticaria and other things. So to avoid this, many institute they actually transfuse albumin totally, but it is not possible for us because albumin is very costly in the commercial market. So we have to mix it. Again, in some institute, যখন আগে PGI Chandigarh ছিলাম, then we used to do this plasma exchange by the fresh frozen plasma, right? Even at SGPGI, we used to do it by fresh frozen plasma because albumin was costly and fresh frozen plasma was quite cheap, right? Now, to reduce the citrate toxicity, what we do, we start actually the calcium infusion during the procedure, right? And this is the rough guideline. It is said that if you exchange one volume, then your 63% of the pathological substance are reduced. If you exchange two volume, then 86% are reduced. And if you exchange 3 volume, it is 95% reduced. This is as per the textbook which I am going. But it depends on you what volume you'll be exchanging. But I think to be in safe side, we should start with 1 volume. Maybe maximum in Indian scenario, we can go up to 1.5 volume, because 2 volume, 3 volume, these are aggressive plasma exchange and it leads to reduction of a lot of normal components also. So what is wise? It is wise to perform 1 volume exchange with repeat procedure daily or alternate days, depending upon the condition. That is our experience, right? And that is our SOP, our experience. Now, plan medication after apheresis procedure well below procedure. এটা একটা খুব important for the postgraduate student. Just if you give an injection or any infusion just before the apheresis procedure. Suppose সকাল 9টায় আমি একটা কিছু injection বা কোনো medicine দেওয়া হলো patientকে, then I started the procedure at 11 a.m. Then almost I am taking out all the medicines through the plasma, right? So that medicine will not be effective for the patient. So what we actually tell the patient, nursing staff or the doctors there, always plan medications after an apheresis procedure or well below the procedure. Suppose I plan the procedure at 12 noon, you can give it early in the morning. একটা যদি 4 থেকে যদি 6 ঘন্টা একটা গ্যাপ পাওয়া যায়, then it works very well. And always it is wise to give after the procedure, right? That is okay, because again next day you will be doing the procedure maybe after 24 hours, and by the time your medicine will work nice. Now, while sharing a few of our actually experience in our hospital at Apollo Hospital, so we actually received the license of apheresis in 17th November 2011, right? And in 25th November 2011, we have done the first single donor platelet procedures, right? And till date, till 2011 to 2024, as I was calculating, seeing the data, we have done more than 7,500 apheresis procedure including the platelet apheresis. Of course, out of which 80% you can see it is platelet apheresis. Now, this is the these are the procedures which we have done. So the total number is 7,561, right? Till last Friday, and out of which platelet apheresis is 5,599, quite a big number. Then therapeutic thrombocytopheresis, around 35 procedures have been done in patients suffering from high platelet count, right? Then 271 stem cell collection করে transplant করেছি, 271 stem cell transplant. তারপরে therapeutic plasma exchange, obviously this is the commonest of all therapeutic procedures. We have done 1,315. Leukapheresis, in some leukemia patient we have done number of procedures around 32. Erythrocytopheresis যদিও খুব কম করা হয়, so we have done 16 procedures of red cell reduction in sickle cell crisis and in malignant malaria. And during the COVID, we have collected 293 COVID convalescent plasma during the plasma trial, right? ICMR plasma trial. So these are the procedures which we have done till date, 7561. Our key procedure করেছি, this one. These are the therapeutic plasma exchange procedure which we have done, considering Kolkata and Apollo Hospital is concerned. So we have done procedure in 87 patients of Guillain-Barré syndrome, 49 patients of myasthenia gravis. So this third column, if you see, we can see the number of patients, and the second column is the disease, the thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, CIPD, acute liver failure, hypertriglyceridemia, pancreatitis. So these are around 11 to 12 diseases where we have done plasma exchange in our hospital, right? And but the majority of the procedures were done in Guillain-Barré syndrome, myasthenia gravis, thrombotic thrombocytopenic purpura, and acute liver failure, right? And বাকিগুলো দুটো চারটা পেশেন্ট বা 10টা পেশেন্ট করেছি, but major it is the neurological diseases and hematological diseases and the liver diseases. আর বাকি apart from therapeutic plasma exchange we have done platelet reduction, 10টা patient we have done, 10 patients we have done essential thrombocythemia তে করেছি, and another 14 patients of secondary thrombocytosis, and this I am talking about since 2011 till date. ডান দিকে লেখা আছে 10টা পেশেন্টের কয়টা প্রসিজার করেছি, 16 procedure, because if you have a sorry, if you have a high platelet count, so 10 lakhs, so it requires only one therapeutic platelet reduction, or in some patient two, to reduce from 10 lakhs to 2 lakhs, but 3 lakhs, but 4 lakhs, right, in the normal range. So you can see here 10 patients of essential thrombocythemia, 16 procedures were done. That means 1.5 procedures per patient, right? Then in leukapheresis, 17 patients of leukemia we have managed with the therapeutic WBC reduction. In case of 16 patients, we have 16 procedures. We have done erythrocytopheresis, there is red cell reduction. তার মধ্যে 9টা patient ছিল sickle cell crisis, where the sickling was more than 80%. So to save the patient, we have to reduce the sickle erythrocytes. আর দুটো ছিল malignant malaria, falciparum, Plasmodium falciparum infecting the red cells, and in one patient the parasite load was more than 3 lakhs. But we could save the patient by doing this red cell reduction, whereby we actually, what happens, we remove the pathological red cells and we have given the blood bank red cells around 8 to 10 units to this patient to save this life, right? So these are some of the procedures we have done, therapeutic apheresis procedure we have done in our hospital since last 12 to 13 years, right? Now, recently, why I am sharing this experience, recently, I think if you go through the literature, you will see that acute liver failure patients have been managed, right, with therapeutic plasma exchange. A number of such patients have benefited a lot, and there are a lot of papers from all throughout the globe, right? It is available in the PubMed search or in the Google also. So we started. So from the as one day, what happens? My head of the department of gastroscience rang me and told me, Sudipta, can we start therapeutic plasma exchange in case of liver failure? Because in last few years we have seen the role of therapeutic plasma exchange in this type of category of patient. Then when you have done a literature search, yes, there are a lot of literature saying that you can do that, and out of which few are in category 1, few are in category 2, and few are in category 3, actually category 3 indications, right? So what happens, we started the project. It started as a project in Apollo Gastroenterology department, where we have dedicated a new cell separator, apheresis machine, for the Department of Gastrosciences, 5th floor daycare building. And this was actually, the plan was done in January 2003, but the new machine came from USA, and it was installed in October 2023 after the Durga Puja. Now, the first procedure was done on 16th October 2023. So now we are running this program very successfully. So in the last around 6 months, we have managed 66 patients of acute liver failure or chronic on acute liver failure, and including both male, 48 patients were male and 18 patients were female, and a total of 251 procedures were done in this 66 patients, right? So in an average, each patient required 2 to 4, you can say 3.5 to 4 procedures লেগেছে একটা patient. So some patient required 3 also, some patient required 5 also. So the mean may be around 4. Now the total mortality due to hepatorenal syndrome, hepatopulmonary syndrome were 10, and we are very lucky that out of this critical patient, 4 patients can undergo liver transplant. And now they are fine after the transplant. Fine. So this therapeutic plasma exchange acute liver failure, it is just to maintain the criticality in the patient. It is not a life-saving or something you can save the patient, but just to maintain the various toxins, enterotoxins, bile acid, and other things, so that the disease can be minimized and the patient can live for a longer time, or the patient can be planned for liver transplant, right? Now, this is the machine which we have installed in the Department of Gastroenterology. Is the Optia fully automated machine. And these are the different indications of liver disease where we have done the procedure. You can see in the acute liver failure, most of the patients were viral hepatitis, mostly hepatitis B and hepatitis C. Others are drug-induced. Recently, we have done a procedure of therapeutic plasma exchange in a lady who has taken paracetamol, around 30 tablets of 1 gram paracetamol, that is a drug induced, and led to acute liver failure. And then post liver transplant, also few patients require plasma exchange to remove some toxins or remove some antibodies which are developed. So in acute and chronic liver failure, most common cause is the alcohol. Yes, you can see out of the 20 patients, 10 are alcoholic liver disease, some are viral, some are infections. Yeah, leptospirosis, craft typhus are also patients which come into gastroenterology, and their conditions of the liver are so bad, sometimes we have to go for the therapeutic plasma exchange. And in one case, we have done autoimmune hepatitis where no other treatment was actually working. So we have to do a plasma exchange in autoimmune hepatitis, right? So these are the category of liver disease where we have done therapeutic plasma exchange, right? And of course, there are 10 mortalities due to various complications, and other 56 are now coming to the outdoor, or sometimes they get admitted and do the plasma apheresis, and they are planned for liver transplant. If you get a suitable liver, then you can give this patient. Now, even I am sharing some data also here on how this plasma exchange has actually taken care of the patient disease, and how it reduce the various toxic factors in the patient. So this is the pre and post therapeutic plasma exchange data you can see in the 66 patient, right? So here, if you can see, the mean bilirubin in the patient were 24.7, range was 14.6 to 13.5. But after mean three procedures, we have seen that 24.7 thing, it name is 9.7, and the value was very significant, right? INR 3.4 came to 1.4, creatinine 1.6 came to 0.9, and obviously plasma apheresis played a very important role in reducing this bile acids, bilirubin, creatinine, and other toxins, right? And if you go through the severity of hepatic encephalopathy or the MELD score is one score which is used for the severity of the liver disease. That is the MELD, MELD, that is the model for end-stage liver disease, and there is a suitable score from 6 to 40. So scoring has been given from 6 to 40. And if you see here, many of the grade 3 and grade 4 hepatic encephalopathy has been converted to grade 1 and grade 2 after plasmapheresis, right? If you see here, দেখা যাচ্ছে grade 1 এ দুটো ছিল আর grade 3 আর 4 এ প্রায় 11টা নোট আছে, না 11 and 9. And if you see this column, next column, these patients has gone to grade 2 and grade 1. That means plasmapheresis played a very important role even reducing the severity of the liver disease in the form of grading of hepatic encephalopathy or the MELD score. If you see in the last row, if you see, the MELD score was 33, mean MELD score was 33 before the procedure. After procedure, if you see, it is 22, right? So the reduction is significant. And this I am not actually, this I have analyzed only for today's discussion. It is not that I am publishing a paper. That will be done, but it is later, that is later thing. But for today's only lecture, we have taken this data so that our students actually see this data and they can realize what is the utility or what is the advantages of therapeutic plasma exchange in a case of acute liver failure, right? So this is the thing. And here you can see that is the effect of serial therapeutic plasma exchange procedure on lab parameters. If you see here ammonia was more than 120, plasma exchange করে তিনটে procedure করে it came to around 40. Again, if you see the blue line, bilirubin more I've seen 24.7 ছিল, নেমে এটা অনেক কম 9 হয়ে গেছে। ওকে, অ্যামোনিয়া, INR, bilirubin, creatinine অনেকগুলোই বেড়েছে। So in the pre-plasma exchange, you see it is more. Post TP1, post TP2, post TP3. So first procedure পরে কমে গেছে, second procedure, third procedure. So there is a, if you see this graph, there is a gradual reduction of this bilirubin, INR, creatinine, ammonia, right? After doing the plasmapheresis. So this is the new machine, and we have been, thanks to the Department of Gastroenterology, Apollo Hospital, so they have given us a room also for placing this machine and doing this procedure in the dedicated room with all monitors, oxygen supply and everything. So this is a person who is undergoing a therapeutic plasma exchange in a case of in the case of viral hepatitis leading to acute liver failure. And you can see here, the black color plasma which is coming in the back side. The বড় bag দেখা যাচ্ছে পেছনে, that is the plasma which of the patient. You can see high color, very black color, সরষের তেলের মতো রং, right? And here you can see I am doing this procedure using a blood bank fresh frozen plasma, and this is in the right side you can see this is the albumin, right? So I am doing it with albumin and fresh frozen plasma, but in the very big bag. This is a very big bag. We are seeing how this plasma, high colored plasma, is getting collected into the plasma wastage bag, what we call it, right? So these are some publications from my department, from the hospital. As Proshunda was saying that therapeutic plasma exchange plays a very important role in neuromyelitis optica. And many big studies are not there, but there are some scattered case reports available in the literature. We have also encountered a patient with neuromyelitis optica, a 16-year-old girl, where we have done therapeutic plasma exchange and the patient life was saved. And the patient is fine now and is undergoing treatment under the Department of Neurology. He visits the Department of Transfusion Medicine and he is very grateful to us that we have saved her, right? So this is one publication in one of the journal, international journal. And this is a very big study where we have done therapeutic thrombocytopheresis, that means therapeutic platelet reduction, as an important tool in the management of symptomatic hyperthrombocytosis. It is a single institutional experience from India, which was actually published in the Asian Journal of Transfusion Medicine. And the total number of case was 36 patients who underwent 82 therapeutic platelet reduction procedure. And if you go, this is available in the PubMed search. It is freely available. So I request the student to download that and go through the entire study which we have done. And it is very interesting also to see how a 20 lakhs platelet, 15 lakhs platelet, how it comes down, what are the challenges, how the patient has to be taken care of, right? What is the end target? So these are the things you can see in this study. And this is one paper which describes the harvesting of COVID convalescent plasma. And this was done during the COVID time, around 2 years back, how this latest generation apheresis machine, it could help a lot of COVID patients. And this is one of the original articles, which is published in the Global Journal of Transfusion Medicine. So if you summarize our discussion today, so there are ample advantages of apheresis technology, not only collecting single donor platelet, but collecting stem cell for stem cell transplant by granulocyte, even in the therapeutic part also, in the patient bedside also, we can save the patient by doing therapeutic plasma exchange, red cell reduction, platelet reduction, WBC reduction in leukemia, where the WBC count comes to 10 lakhs, 14 lakhs again, right? The highest platelet count which we encountered in an 85 years old gentleman was 27 lakhs platelet count, right? He was suffering from essential thrombocythemia, but he was not aware that he was having a so high platelet count. But unfortunately, he developed a coronary artery disease, and with chest pain, he came to the emergency, and he was taken for some angioplasty or maybe a CABG, right? But when they have done a CBC, then the CBC count came to be 25 lakhs, right? Now, actually, when this report went to the physician, doctor, treating physician, he was very surprised. And what he thought that the report is মানে ভুল হয়েছে. It may be not 25 lakhs, it is 22.5 lakhs. So there may be a change of the decimal or something. Again, he repeated the platelet count, but again, the platelet count came out to be 26 lakhs. Then, through the macroscopy studies, they found to be essential thrombocythemia. They have done a molecular study also. Then the patient was shifted to CABG, and CABG was done. But before that, we have done 3 procedures of platelet reduction from 25 lakhs. The first procedure came to 13 lakhs, from 13 lakhs to 9 lakhs, from 9 lakhs to 4 lakhs. So it came to 4 lakhs, then only the patient was taken for a cardiac surgery. So this is the beauty of apheresis procedure, right? So, and a completely a teamwork. It is not that only Proshunda is there in medical college, I am here at Apollo. It is not possible single-handedly. So you need the doctor, you need the technical staff, you need the nursing staff. So it is a totally a complete teamwork, and you should follow your SOP. There is no shortcut, right? You should follow your SOP. You should recruit dedicated trained operators. Your vein should be very good. So as I was talking that in therapeutic procedure, at least you need 3 to 7 procedures, right? Even 10 also. So you always use the central line for that. So it will be very easy for you, because almost every day, 24 hours, you need a apheresis in a particular patient, right? And be a master of the machine, because these machines are all automated, computerized machine. Always there will be some troubleshooting. More and more you use this machine, more and more you are acquainted with this machine, you can be a master of the machine to solve this trouble, right? And another important thing, the donors and patient safety is the first issue. Always you should take care of the patient you are doing from plasma exchange, because you know there may be a hematoma, there may be some neurological complications, or there may be some cytotoxicity. So always there should be prophylactic measures by which you can prevent this type of side effects of apheresis, right? Uh, Either it may be a platelet apheresis, or it may be a therapeutic plasma exchange or other therapeutic exchange. And complete documentation. Sometimes we do the thing so nicely, but we actually document it very poorly or never document, because these are all legal procedures. So you have to document each and every procedures as per the policy and protocol. That is my actually advice to my students also, to the PG students. Thank you.
Thank you, Dr. Sudipta, for your elaborate presentation on apheresis, which involves
You.
both collection of the platelets, which is very important, especially during the dengue period, and also the centers having hemato-oncology setup is mostly needed, and it's really a very elaborate one, and thank you again for that. And one of the thing I want to highlight that there are 2 types of apheresis which is ongoing. One is performed in the nephrology department mostly. The difference between nephrology as well as the blood center or transfusion medicine machines are cell separators. Cell separators work by centrifugation technique, and in nephrology the dialysis where the apheresis also, plasma apheresis also done, they are basically done by the membrane. So there are advantages and disadvantage in both the system, but over the time, it is the cell separator technology for apheresis which has proven itself for its variability of application, because many issues, because dialysis machine cannot extract the excess amount of platelets. It cannot extract the cellular in case of leukostasis. In leukemia, sometimes patients suffer for leukostasis where leukapheresis is done. So these procedures cannot be performed in a dialysis machine. So over the time, cell separator has overcome, even in cases of critical ABU incompatible transplant, where we can use this added filters also. We use immunoadsorbent column, which is not so much adaptive in the dialysis machine. So these are the advantages. The only thing in apheresis in a cell separator, it is the bit costly procedure. And to make itself, to aware all of you regarding that, in medical college also, as we work in a very resource constrained setup, we have arranged for a transfusion medicine clinic every Wednesday. If some critical cases they come for opinion, we can admit those patients and give them the opportunity under our care also. So this is for the awareness. Now I move to the question and answer session. I think one or two questions. First question is whether plasmapheresis does plasmapheresis cases. So Dr. Sudipta, please answer.
Yeah, please tell the question again. Your voice was not clear.
Does plasmapheresis have a role in IVIG failure in GBS?
Yeah. So actually, if you go through the categories of category 1, category 2, category 4, it is beautifully described in category 3. It has not come in category 2, category 1. Actually, what we have seen down with time, যেগুলো আগে category 3 তে ছিল, প্রসুন্দা, what we have observed, now it is gradually coming to category 2, and even there are some diseases who are in category 2, they have been come in category 1 with more randomized controlled trial with big multicentric studies, right? Even I think you remember we started acute liver failure plasmapheresis. We started with category 3. Now, if you go the ASPA guidelines, 2023, now it has gone to category 2, and even some again in category 1. So
Yes.
Now this
Right.
IVIG failure in GVSD, it has come in category 3. Maybe there is no much actually evidences on that. Maybe in the future with more studies, it will come in category 2 or category 1 also.
Yeah,
but obviously
here
it has a
I
role.
can say one thing to add, because plasmapheresis has to be initiated as early as possible. The more you do, it becomes late. The plasmapheresis or plasma exchange do not work so much in case of Guillain-Barré syndrome also. So it should be initiated at the earliest. That is one of the. Another question is, what is your view on cytokine hematobsorption?
Actually, nowadays, as we were talking about use of columns, right? So when we talk about therapeutic plasma exchange, what do? We remove the entire plasma. সেই প্লাজমাতে সাইটোকাইনসও চলে গেল, অনেক কিছু চলে গেল, right? And we give the normal plasma. But as Prashunda was speaking on columns available, suppose we want to reduce only NTB antibody. Suppose একটা ABO incompatible transplant হবে, and the recipient and the donor, we have done the blood grouping, and it has found to be incompatible. Now our aim is to reduce the NTB antibody. Now there are columns available which can be fitted to the apheresis machine, and that columns, they are having the B ligands, okay, B antigens er moto B ligands. So when the blood goes through this column, the NTB gulo ligands gulo to lege, then it reduces the NTB concentration, NTB titer. Similarly, there are columns which have been developed, not used in our country, in the developed countries, for various cytokines and chemokines also, right? Where we have columns like this, which will specifically or non-specifically, they will take up the cytokines, maybe the cytokines which you are not taking care of all the cytokines, and you will the plasma which the patient is getting again through the after the apheresis, it gets a cytokine free plasma. Yes, there are columns available for cytokines also, chemokines also. Almost there are 100 columns now available globally by which you can do very specific therapeutic plasma reduction using that column. কিন্তু এই কলমগুলো কিন্তু অনেক দাম, right, Prasunda?
So
I think in terms
for
of lakhs.
cytokine absorption, it is required. The columns are specific.
Specific, right.
So another question is there any option for alternate plasmapheresis and hemodialysis? So what's your opinion?
See, there are
So
some
as
conditions.
I was discussing, plasmapheresis and hemodialysis, dialyzing machines, and so just explain.
See, it depends upon. So dialysis machine should always be done for only dialysis purpose only, not for this type of plasma reduction or something, right? Because dialysis machine mechanism is different, as Prasunda was saying. We do the centrifugation, we take out the entire plasma. Now, in dialysis machine, that is the filtration procedure, right? Many of the things will be retained, many of the things will be out. So that is not a specific machine for a therapeutic plasma exchange, right? So if the patient is having suppose the patient, in many liver patient, what we do? We do plasma exchange, then dialysis. We do plasma exchange, we do dialysis. Why do you dialysis? Because the patient is concurrently suffering from the hepatorenal syndrome also. So we do a dialysis, that is indicated. But in case of Guillain-Barré syndrome, that is a therapeutic plasma exchange is the treatment. There is no dialysis part in that. If there is a dialysis required, obviously you can do a dialysis. Even in the morning, you can do a therapeutic plasma exchange. Evening, you can do a dialysis if the patient requires the dialysis. But that is not a substitute of therapeutic plasma exchange, right? So actually, when we have not started the therapeutic plasma exchange in Apollo Hospital, most of the Guillain-Barré other things, they have to be referred to the dialysis unit to a nephrologist. With the start of transfusion medicine with apheresis, now all cases of this Guillain-Barré and other things which were previously done on dialysis now are done on the apheresis machine, because the result is also fine. তো বলবে, আরে সুদীপ্ত 60টা প্রসিজার করে নিয়েছি ডায়ালিসিস মেশিনে, কিছু তো আমি রিডাকশন পেলাম, they will come to you. Then if you do, then by 2 or 3 procedures you will get the suitable result. So these are from the treating physician itself. But of course, if it is indicated dialysis, you have to do that.
So exactly, dialysis may be cheaper, but it cannot always replace, because the cell separator actually removes the thing. But in a dialysis machine, the osmotic gradient, the things are exchanged, so that filters rather. And
Right.
another thing is, in a dialysis machine, the blood flow must be in a high flow rate to overcome the osmotic barrier. So, but in case of cell separator, you can adjust 40 to 50. The new modern cell separators which we are talking about, even in medical college, we have the same machine. So here we can adjust the blood flow rate also 40 to 50 milliliter, where we can perform the procedure. Only thing is the procedure may take a bit time, but it's okay for the patient. So cost is one of the hindrance in resource constraint setting. That's why dialysis machine more the apheresis is going to perform, but it cannot be alternate to the cell separator related procedures. And immunoabsorbent columns are very expensive, as Prosorba, Lysosorb, this sort of columns are available, which can be added, but cost of each column is almost a few lakhs, and only they are permitted for single procedure, not reusable even, although they are reused, but they are not permitted to be reusable. So these are some of the constraints in the setup. So with this, I don't find any more questions. So thanks again to the API, Ganguly sir, Apurva Mukherjee sir. They are my teachers also during course of time. It's a very pleasant for me to face all of you. Thank you so much. Thank you, Dr. Sudipta, for your excellent deliberation.
Thank you, sir.
Thank you.
Thank you,
okay,
sir.
bye.
Thank you, Dr. Kushal Bhattacharj and Sudipta. Now it is our protocol to give vote of thanks by Dr. Rothin Sarkar, who is one of our course directors. Rothin, please.
Yeah.
Thank you,
Thank you,
sir.
Amulda. First of all, I must thank and congratulate Sudipta for a very nice, and I think it is one of the best, I think, needful lecture in our master class series, which the PGTs will be enlightened with. And Prosun, thank you very much, seeing after a long time after medical college. And I must also thank him, and also I must thank all my colleagues in the ICP and also the PGTs, and last of all, to the backup staff of our API office. And now over to Amulda.
Thank you, everybody. I must say one thing, that I have seen Sudipto only once in my life in a lecture in Apollo, and I was very much impressed. So from that, I wanted that some of our PGT must learn this, and Prosun developed this word in the month I retired from medical college. Now I request both Sudipto and Prosun to initiate a course of MD or DNB in our state, so that more and more young people learn this.
MD transfusion is in medical college is a recognized, 2 seats are there.
Oh, very good, very good.
DNB is
Very good.
organized recently in Tata Medical Center Hospital. I think Sudiptu is also going
I have
to start.
applied, sir. I have applied this year for DNB transfusion medicine, and hopefully it will be approved, and next year we can take 2 seats.
So more and more youngsters will know this, and then society
course,
will
sir.
be benefited. Thank you.
Of course, sir. Thank you, sir.
Thank you.
Thank you, sir.
Oh, nice.
Thank you, Sudipto and Prosun.
Thank you, sir.
Particularly Sudipto for taking up some issues which are highly specialized. Though
Thank you, sir.
it is progressively becoming more beneficial to different clinical scenario. Anyway, we are going to adjourn this master class till 12th of May, when we will resume again to discuss diabetes mellitus beyond type 1, type 2. I express my sincere thanks to all our course directors, and of course to speaker and chairperson, making it a very fruitful academic, at the same time very practical and also encouraging sessions. So more and more PGTs and physicians, they are prone to take up apheresis as and when required. Thanks to all.